morning, everyone. Good afternoon. And thank you very much for joining us today. My name is Miray Shernikul. I am a medical director for Getinge, responsible for critical care products. And today we have an excellent speaker from Belgium, Professor Dr. Manu Malbrain. And then first we will have my colleague, Dr. Mark Conrad, will make an introduction, and then we will hand over to Professor Malbrain for his presentation. And if you have any questions, please use the question and answer section. We will have a Q&A session after Dr. Malbrain's presentation. So thank you very much once again, and now I leave the words to my colleague, Mark.
Yes, thank you very much to everyone. We're going to have a very interesting talk today. Please be aware of our disclaimers first. The talk is for educational purposes only, and whoever knows Manu Malbrain knows about the content of his slides is very effective and very interesting, so we're really looking forward to an interesting talk. Manu Malbrain, he's a professor of medicine at the Brussels Free University. He's the director of ICU at the University of Brussels. And he's the co-founder and the past president of the World Society of Abdominal Compartment Syndrome. And that's also why we invited him today as presenter for the link between the ventilation and the hemodynamics. He's been granted many grants. He's also a member of the Getinge Advisory Board and is a speaker at a lot of international conferences. I want to say one more word to question and answers. Be aware that in this in the question and answer window, there's two tabs. One is the attendee chat, and the one just next to it is the question and answers chat. So please be aware to click on the question and answers chat before you enter any questions. And with that, I want to thank you, and I want to hand over to Manu, and we're very much looking forward to your talk.
Thank you, Mark. Thank you, Miray. It's my pleasure to give this lecture on the impact of COVID-19 on hemodynamics and respiratory system, and what the role of abdominal pressure could be. So if water is a problem, and fluid overload, then de-resuscitation or removing the excess of fluids may be the solution. These are my disclosures, and my biggest bias being the co-founder of this illustrious society, which is the Abdominal Compartment Society, which was founded in 2004. This is Noosa Beach. It was winter in Belgium, but full summer there. Unfortunately, we had very bad weather, and we were very happy to have Fox Creek Wines as a major sponsor of that meeting, which would now probably not be possible. I have a definite huge bias on intra-abdominal pressure measurement, and this is a present given by trainees whilst I was still working in Antwerp. And I usually say, whenever I ask a question, the answer is intra-abdominal pressure. I've been very grateful to meet Mathilde, Queen of the Belgians, during the terrorist attacks a couple of years ago whilst working in Antwerp. And this year, because of the COVID crisis, we had a visit of Philip, the King of the Belgians, visiting our hospital. I also had the possibility to meet Maggie de Blok, our Minister of Health. And while she advocated everyone to stay in their house, I think now it's time for politicians to get out of, in Belgium, they say, co-terrain. I don't know the English word, but it's the poor condition that politics are dealt with in Belgium. But it's not about politics today. So I would like to give you a brief overview of COVID-19 situation in Belgium. We had at one point in time about 6,000 hospital admissions, patients admitted to the hospital, out of which about 1,500 in the ICU. The ICU capacity in Belgium normally is 1,900, and we upscaled to 2,600 beds, so we never breached the capacity. Mortality, on the other hand, was very high, and we had about 10,000 people dying from COVID-19, about half of them in nursing care homes. So it's always the way how you count the numbers. This is data from pooled data from 5 hospitals, about 3,000 patients, where you see average hospital mortality is 11%. For the ICU, it's about 23%. Patients who are mechanically ventilated, overall mortality 28%, and those in the ICU not ventilated around 19%. So how did we do it in Brussels? This is the evolution of admissions. Below in red, it is the ICU admissions, and at some point we created 10 extra beds, and the highest number we had at one time was 34 patients. In the hospital, around almost 500 with mortality of 16%, and in the ICU about 125 patients with mortality 23%. So we were quite happy with these numbers, as normally you would expect a mortality rate about 50% in severe ARDS. So we conducted a small survey, basically amongst intensivists with experience between 10 and 25 years. And if we ask them, how do you perceive that the corona crisis was dealt with in your country, the net promoter score was very, very bad. It was better when we asked them how the hospital and the ICU dealt with the crisis, but still this was a very, very severe crisis where all our colleagues all over the world had to deal with. If we then asked if people used fluid stewardship in the ICU, it's only a minority. Early vasopressors are used, but bioelectrical impedance analysis not so used much. Lung water measurements not so much. Abdominal pressure was quite happy, used in about 60% of respondents. So my lecture today will be about breaking some bad habits. And the learning objectives will be to understand abdominal pressure, abdominal hypertension, abdominal heart interaction, abdominal lung interactions. Then some pitfalls of transpulmonary thermodilution, volumetric measurement of fluid status. I'll talk a little bit on fluid therapy, not too much, and focus on fluid overload and how to de-resuscitate or how to guide de-resuscitation and how this may have an impact in patients with COVID-19. My talk will be based on some recent papers that are available as open access, and of course we'll be willing to share them with you after my lecture. So basically on fluid management, fluid stewardship, and also some thoughts on fluid therapy in COVID-19 patients. Also, we'll focus on fluid overload and de-resuscitation, how to ventilate patients with abdominal hypertension. Recently published a clinician guide to the management of abdominal hypertension, and also ventilatory support in patients with fibrotic lung, which may act as COVID lungs in a later stage, and the squishy ball principle. Common pitfalls and tricks whilst performing transpulmonary thermodilution. And then very briefly, I'll point towards novel techniques to assess fluid status like bioelectrical impedance analysis. So let us go to the case or cases. And I have to say there is some fact and there is some fiction. The fact is that the data are real, but it's not multiple cases. It is in fact all the different problems that we encountered in the different COVID patients brought into one case. And let us jump and dive into this case, which is an amalgam of different COVID patients. A woman of 62 years old, a high body mass index. This is what we saw, is that majority of the patients had a high body mass index with pre-morbid conditions like hypertension, diabetes. and the patient was quickly deteriorating and intubated, mechanically ventilated. We performed high-resolution CT scan, and this was part of our triage system, because initially we had to wait about 6 to 8 hours for the COVID PCR. So based on CT findings, they got already a label, probable COVID pneumonia. Our radiologist graded them according to the lobes and the segments, and this patient had about 64% of lungs affected by COVID. In collaboration with IcoLung and Icometrics, we performed some artificial intelligence on the lung imaging, and we were able to calculate automatically the amount of ground glass, crazy paving, and consolidation. The biomarkers in our patients were highly increased, so high inflammation with a high CRP and procalcitonin, a very high neutrophil lymphocytic ratio. Also, other markers from heart failure were present, and then markers for coagulopathy also increased. So we already assumed that bad things could happen with this patient. ECG showed sinus tachycardia, and was performing a quick look ultrasound. We found an inferior vena cava collapsibility index of about 50%. Patient being in shock with lactate and a drop in SCVO2. So this is at baseline in the ICU, the monitoring, and what struck us was the increase in central venous pressure of around 17 millimeters of mercury. So patient in shock with lactate, we usually go for hemodynamic monitoring. In our hospital, we use transpulmonary thermodilution. And this is an impression of how in the future our hemodynamic cockpit or dashboard could look like. Once we would collect the hemodynamic data, this would go to the cloud and would give the doctor an advice that in this situation, about 100% of our colleagues would give the patient fluids. So this is real, but it doesn't look that fancy. What we have is an Excel sheet with a Visual Basic where you can enter the hemodynamic data, where you can state whether the patient is in shock or respiratory failure, and where a suggestion comes out. So the patient was resuscitated with some fluids, plasma light, 4 ml per kilo. And looking at a decision tree, if we look at the value of cardiac index is low, global end-stolic volume low, lung water is low, so this patient may benefit fluids. And this is exactly what we did. And the decision for that is multifactorial, like patient being in shock, low volumetric preload, no evidence of extravascular overfilling, high PPV, passive leg raising positive, and this despite the high CVP. So CVP is a barometric preload indicator. In order to assess correctly, we need other information. So something is missing. And in fact, what is missing is that the central venous pressure was probably falsely increased due to the increase in intra-abdominal pressure, around 16 millimeters of mercury. So this brings me to a first interludium on some background on abdominal hypertension. And when we published the consensus paper in 2006, we never would have realized that it would become one of the most cited papers of intensive care medicine, with up to now over 1,600 citations. So in 2013, we published a revised guideline. It's available open access. And now we are working on another revision, which will be due probably next year. So normal abdominal pressure is around 5 to 7 millimeters of mercury and may vary with underlying conditions. The higher the pressure, the more the impact on end organ function. Usually in ICU patient at baseline, we see pressures of around 7 to 10 millimeters of mercury, which are also higher after emergency abdominal surgery. Abdominal hypertension is defined as a sustained elevation in pressures above 12 millimeters mercury, and failure to intervene when this pressure remains very elevated is associated with poor prognosis. So classification goes with a grading system from grade 1 to 4 with the cutoffs that you can see on the slides. So compartment system is defined as a pressure above 20 millimeters of mercury with new onset organ failure and dysfunction. And it can be referred to as primary, which refers to a condition in the abdominal cavity, or secondary, which is usually the case in sepsis or patients with burns and massive fluid resuscitation, as was probably also the case in our COVID patients. So when we look at the abdominal cavity, it can be seen as a fluid compartment. And when we exert a pressure, the pressure is uniformly transmitted and is dependent on gravity, shear stress, probably also contractions of the abdominal muscles. So this refers to a condition that is called the Polycompartment Syndrome. When the pressure in one compartment is increased, it will be transmitted to the other compartments, like from the abdomen to the thorax to the brain. And on average, this transmission is about 50%. So when the volume in the abdomen increases, being it after fluid overload, the shape of the abdominal cavity changes from ellipse to a more sphere-like structure. And this is what we refer to as reshaping, followed by stretching and pressurization. So compliance may be the key, and the abdominal compliance is the measure of ease of abdominal expansion. And it's often neglected, especially in critically ill patients, but may be a key factor in explaining organ-organ interactions. So how then can we measure the intra-abdominal pressure? We can do this via the bladder, the stomach, or direct intraperitoneal or via rectal pressures. Can we estimate abdominal pressure by putting one hand on the abdomen? Surgeons usually believe they can, but this is not a good way, neither using two hands and shaking a little bit or the abdominal perimeter. This is not sensitive and specific enough and is not accurate. So we need to measure. So what about direct measurement? As you can see in this video from the ER series, in a patient with severe pancreatitis admitted to ICU, the abdomen is punctured, ascites is coming out, and the height is 42 centimeters of water, which is 31 millimeters of mercury, which is sufficient to cause end organ damage and failure. Direct measurement is not advocated in the ICU because it's invasive, can lead to infection and bleeding. So the gold standard is via the bladder, after instilling a maximum of about 25 mL into the bladder. Should be measured in supine position at end expiration, with the zero at the level of the mid-axillary line. And as the height of urine is the gold standard of any pressure measurement, you could use a Foley manometer, which is illustrated in this video. You put to the zero reference, so normally should be the mid-axillary line, and you open a biofilter, urine comes down, and the height of the urine column equals the pressure in the abdomen. You could use a nasogastric probe and measure via balloon continuously the pressure in the stomach. The bottom line is that on average, about 1 in 4 patients has abdominal hypertension. 50% may develop it within the first week. 5% of ICU patients will develop abdominal compartment syndrome with a very high mortality. So you need to measure the pressure in order to know. And this probably is also the case in patients with COVID. So the problem is, after fluid resuscitation in situation of capillary leak, you have third space fluid accumulation, pressure in the abdomen increases, bowel edema, compression of the vena cava, reduced blood flow returning to the heart, cardiac output drops, reduced flow to the organs, and this may lead to multi-system organ failure, creating a vicious cycle with ongoing fluid resuscitation may worsen the condition. Being an internist, I got fascinated by abdominal hypertension over the last 20 years or so. And increased abdominal pressure has a tremendous impact on end organ function, not only within the abdominal cavity, but also outside. And this is just a small list of the cardiovascular and respiratory effects of abdominal hypertension. So the first being an increase in barometric preload, as was the case in our patient, where CVP was around 17 millimeters of mercury. So if you would have a combination of abdominal pressure and central venous pressure, you could calculate the index of transmission, which I told you on average is about 50%. So by subtracting half the abdominal pressure from the end expiratory CVP, you could have a better estimate of preload. So in general, when abdominal pressure increases, you see an increase in CVP and you see a drop in global end-systolic volume. So this is why volumetric preload is better in patients with abdominal hypertension. Has been shown by other studies and is illustrated in another review paper, also freely available. So back to the case, after the fluid loading, we saw an increase in the end-diastolic volume, a little bit increase in the lung water, cardiac index improved, and still PPV around 16%. Lactate increased and SCVO2 is not so good. When we asked the computer, a bit hesitating, giving more fluids or using fluid removal, we opted to give a small bolus of fluids. And if we put this into the decision tree, then you can see now with a better cardiac index, a better volume, the question is to give more fluids with a question mark. And the question mark comes from the fact that lung water already increased a bit. So this gives us a therapeutic dilemma with a patient who is intravascularly underfilled, fluid responsive, but at the risk of creating more pulmonary edema. At this point, PF ratio was below 100. Brings me to the impact of abdominal pressure on lung mechanics. And ventilatory failure is an imbalance between ventilatory capacity and ventilatory load, which mainly reflects the chest wall compliance. And if you see that the factors predicting this are associated with abdominal distension, abdominal hypertension, fluid overload, and ascites. On the left-hand side, you see a normal lung, and chest wall elastin only plays a minor role. On the right-hand side, you see a patient with abdominal hypertension, or also the patient with fluid overload. And there you see that the impact of the chest wall on total lung elastance, which is the opposite of compliance, becomes more important. So let's illustrate this. If you would have a sticky atelectasis requiring a transpulmonary opening pressure of 30 centimeters of water, and I would apply an external pressure of 60, in a condition of a low abdominal pressure, the relation between total lung and chest wall elastance is reflected there, about 60%, and then the applied pressure would result in a transpulmonary pressure of 36, and the atelectasis is opened. On the contrary, abdominal pressure would be 20 millimeters of mercury or more, then chest wall elastin becomes much more important, and then the transpulmonary pressure would only be 24, and there would be no recruitment. So this is illustrated by this PV loop, where you can see that whilst increasing alveolar pressures, you have ongoing recruitment. And this is summarized by these opening pressures at normal intra-abdominal pressure. But if you have abdominal hypertension, then you see that the opening pressures are shifted to the right. So you need higher pressures in order to recruit the lung. On the other hand, if we look at the expiratory limb, then you see that the closing pressures also are increased in patients with abdominal hypertension, which means that you probably need higher pressures, higher PEEP in order to keep the lungs open. And this is why, as a simple rule of thumb, in patients with abdominal hypertension, after recruitment, you can set the PEEP equal to the intra-abdominal pressure, so the PEEP in centimeters of water, abdominal pressure in millimeters of mercury, to counteract these effects. And this is illustrated by this video. On the left-hand side, you have normal abdominal pressure, and on the right-hand side, you have increased intra-abdominal pressure. And you see after muscle relaxants, there is dorsobasal atelectasis. Another point is that in patients with capillary leak and fluid overload and increased extravascular lung water, that there is a sort of exponential effect. And this is illustrated by this PIC model. On the top end, you have normal abdominal pressure. So if I apply alveolar pressures of 40, the lungs are recruited. On the bottom now, abdominal pressure is increased until 20 centimeters of water. So you see for the same alveolar pressures applied, only half of the lung is recruited because transpulmonary opening pressures are probably not 40, but 20. And when it comes to lung water in normal abdominal pressure, it's in the dorsobasal regions. But if I increase abdominal pressure, you see that the whole lung gets flooded until the apex of the lungs. So back to the case, PF ratio was worsening. We already tried prone positioning, abdominal pressure increased, a positive fluid balance, and we had evidence for capillary leak with a high lung water, a high PVPI, pulmonary vascular permeability index, and a high capillary leak index, which is the serum CRP divided by the albumin. So the situation dramatically worsened, and we tried to recruit the lungs and open the lungs. For that, we usually do a low flow PV loop, and you can see that there is an inflection point, the best PEEP probably being around 15 centimeters of water. Whilst doing so, we had to increase norepinephrine, added some dobutamine. We were on 100% FiO2. And whilst performing this PV loop, blood pressure dropped dramatically. So we tried APRV, airway pressure release ventilation in combination with the prone. And we performed cardiac ultrasound, where we saw some septal dyskinesia, D-shaping. And we saw tricuspid regurgitation and the right heart, which is dilated, with pulmonary hypertension calculated towards about 60 millimeters of mercury. So in summary, this transthoracic ultrasound showed a not dilated left ventricle with reasonable function. Right ventricle was dilated, function diminished, increased ratio, some D-shaping, and tricuspid regurgitation with pulmonary hypertension. So again, putting the new PICO parameters with an increased global anastolic volume and an increased lung water into the hemoguide cockpit, and also noticing that we had a sodium of about 149 at the time. Now the computer says with great certainty that fluids should be removed. Now what we did in view of the high pulmonary pressures is starting nitric oxide inhalation in combination with milrinone and fluid removal by the use of a combination of diuretics with also indapamide in order to remove the sodium. On the decision tree, you can see now that cardiac index is good, but volumetric preload and lung water are high, so it's advocated to try to remove fluids. And that was exactly what we did. But then suddenly the patient collapsed, and you can see here cardiac index is 1.1. And this is the transpulmonary thermodilution curve, where you see after the injection, you have a cooling, and you think the curve is finished. But then comes the rest of the thermodilution curve. And this is a very abnormal transpulmonary thermodilution. And we asked ourselves what could be wrong with the patient. And you can see here on pulse contour, cardiac index of 0.7, very low global endostolic volume, and a very high lung water. These are the raw data of the thermodilution curve. So you can see there is a sort of premature hump, and then it falls back to normal. Entering these numbers into our HemoGuide cockpit, well, I think the computer didn't know either, because we should either give fluids, remove fluids, increase inotropics, decrease inotropics. So if the computers doesn't know, well, we decided to give some of all, some inotropics, some vasopressors, some fluids, and we performed controlled transthoracic ultrasound. But going back to this funny thermodilution curve, it looks like a camel curve. And we have to ask for questions whether maybe the measurement was wrong and the nurse performed a wrong measurement, whether it could be a crosstalk phenomenon with central venous line and pico-arterial line close to each other, but it could also be a right to left shunt. Again, when we entered the numbers into our decision tree, very low endostolic volume, lung water increase, but this could be falsely increased. Again, a lot of question marks, either some volume or catecholamines. So we checked again transthoracic echo. Now you see that left function is decreased, right heart is dilated. And there is tricuspid regurgitation. Blood pressure at the time was very low, with pressures of about 60/40. And this is the apical four-chamber view, where you can see a very dilated right ventricle, barely moving. This is the ejection fraction calculated about 20–25% of the left ventricle. This is the TAPSE, about 0.8 centimeter. And this is the tricuspid regurgitation, pressures about 20 millimeters of mercury, and the vena cava is dilated and not varying with respiration. So in summary, this ultrasound shows us a normotrophic, not dilated left ventricle, but hypocontractile, with a small pericardial effusion. Septum is paradoxal. But the right ventricle is massively dilated. There is pulmonary hypertension, around 40, with systolic pressure at the time of 60. And the vena cava is dilated without respiratory variation. So getting back to this double hump, this is when you inject femorally and detect in the femoral artery, has been described by Friedrich Michard as the camel curve. But already in the last century, in the 1950s, Swan from the Swan-Ganz catheter described this double hump phenomenon after injection of indocyanine green in children with cyanotic congenital heart disease, indicating right to left shunt. So let me explain to you this double hump. If I instill a bolus for the thermodilution and there is an open foramen ovale and a right to left shunt, a small part of this cold bolus will arrive and create the thermodilution curve. With a delay, the other bolus will arrive, and hence you can have this double hump curve. And this is what you can see when you do contrast echo, is that immediately you see the right to left shunt with bubbles passing the foramen ovale. So our tentative diagnosis at the time was that the patient had massive pulmonary embolism, too sick to be transferred to angio, and we administered thrombolysis. And if we then look at the evolution of the transpulmonary thermodilution curves, then you can appreciate that this hump is decreasing over time, and on day 8 was completely normal. This is the initial thermodilution curve with the obstructive shock and the pulmonary embolism, and this is after thrombolysis. So 3 weeks further on the road, patient is getting better, got tracheotomized, 2 liters of oxygen, sitting in the chair. So we were very, very happy that the patient was able to leave the ICU. Until suddenly, over 24 hours, was again a dramatic evolution with increase in the biomarkers and devastating evolution on control CT scan at the time, with ground glass opacities in about 100% of the lung fields. So we wanted to prone the patient, but we're still struck with the abdominal hypertension. And if you look into the literature on the impact of proning on abdominal pressure, you can see that if you would put the patient on a foam mattress, in green, there is a more significant increase in intra-abdominal pressure compared to a dynamic air cushioned mattress. And we looked this up in a small review, and we found that in patients with abdominal hypertension, compared to baseline in the supine position, you can see that abdominal pressure usually increases with about 3 to 4 millimeters of mercury. So ending up in the range of abdominal hypertension, which is above 12 millimeters of mercury. So there comes the rationale of unloading the abdominal cavity during the prone position. And there is some publications that we should unload the abdomen by putting suspensions on the chest and on the symphysis pubis so that the abdomen can hang freely. By doing so, we will decrease chest wall compliance. So we performed a clinical review on the impact of prone on abdominal hypertension, with or without suspension. And it's probably related to abdominal compliance. So if you would have a patient with normal intra-abdominal pressure, proning with suspension will probably not increase that much intra-abdominal pressure with a great improvement in PF ratio. If you would have a patient with a low abdominal compliance, then when the abdomen hangs freely, you have a kind of gravity and suctioning effect with an improvement in compliance and an improvement in PF. But if you have a very compliant abdomen, then you will see the greatest effect on improvement in dorsobasal recruitment and PF ratio. So unloading the abdomen is important, because if you don't do so, you have a decrease in abdominal compliance and you have dorsobasal atelectasis. If you use suspension, you locally decrease chest wall compliance, you improve abdominal compliance, and you have dorsobasal recruitment. So there is a merit of unloading the abdomen because gravity improves abdominal compliance and decreases intra-abdominal pressure. There is not much evidence-based medicine, but it seems that also weightlessness is good for ARDS. So let me tell you one more thing. If I would reduce chest wall compliance by putting a weight on the chest, this then may improve gas exchange, and also in patients with abdominal hypertension. So putting a weight, for instance, of 10 kilos on the chest in this small study of 11 patients showed an improvement in PF ratio, whilst PCO2 remained unchanged. And in our ICU, we do this by putting 10 liters, so a box with 2 bags of 5 liters of substitution fluid. And when I looked it up, I found that there is even a patent filed by the group of course, Luciano Gattinoni, having a combination of a mechanical ventilator with a compression of the chest to decrease chest wall compliance and hence to recruit the dorsobasal lung regions, avoiding prone positioning. So the other thing is that negative abdominal pressure could be useful to reduce intra-abdominal pressure and to improve abdominal compliance. So here you see with the negative external pressure, you can reduce intra-abdominal pressure. As also be studied in pigs, and you can see that external negative pressure increases compliance, and this was mainly in pigs with abdominal hypertension. So this could be very useful. Instead of proning patients, we could use the combination of applying a weight on the chest with a vacuum on the abdomen. So this would result in a decrease of chest wall compliance, an increase of abdominal compliance, and dorsobasal recruitment. If we refer to the cartoon of proning with suspension, and we turn the image upside down, you will see that the combination of a weight with vacuum on the abdomen has the same effect as proning. So let's go back to the case. Our case that dramatically deteriorated after 3 weeks with again 2 white lungs on chest X-ray. And you will appreciate here that there are 2 tubes. And yes, in fact, the patient was put on extracorporeal membrane oxygenation, VV ECMO. And you can see here, because the patient also had a high body mass index, and this has been on national television, the relation between high body mass index and deleterious effects of COVID. So whilst on ECMO, we had initially a dramatic capillary leak with a very positive daily and cumulative fluid balance, the dotted line representing 0 balance. And recently we also have beds in the ICU with automatic weighing. And you can see that indeed the daily weighing of the patient, we ended up with an extra 6 kilos of body weight, of course related to fluid overload. So because of the fluid overload and the capillary leak on ECMO, we started with CVVH and aggressive ultrafiltration, guided by the device on the right, which is the bioelectrical impedance analysis, which allows to assess fluid status and a separation between the extracellular and intracellular fluids. This is the volume excess measured by BIA, and you can see that it's plus 10 liters and correlated nicely with the cumulative fluid balance and the daily weight. And using the CVVH and ultrafiltration, you can see that the volume excess measured by BIA decreases. And another interesting evolution is in blue, the total body water. In orange, you have the extracellular water, and in gray, the intracellular water. In healthy conditions, most of our fluid is intracellular, but you can see here at some point that the extracellular amount of fluids increases. And this is indicative for capillary leak. So the ratio between extracellular water and intracellular water in blue should normally be around 0.7, 0.8, but you can see in this patient on ECMO that it was above 1.2, 1.3, indicating capillary leak. So the CVVH also allows us to control the sodium balance. You recall that the patient had a sodium of 140 now, with even increased up to 160. And by applying the metabolic control, we could get rid of the excess sodium, because if you don't do so, you will not get rid of the excess fluids. Sodium overload may even be worse than fluid overload. So after the fluid removal, the lungs were cleared again. And after 40 days, this patient was able to leave the ICU, and all went well. And we could end here and say that's all, folks, but there is always an epilogue. And COVID is a very, very strange disease. And 2 weeks later, the patient was on the ward, revalidation, suddenly chest X-ray from one day on the other turned white again. CT scan at the time again showed the same pattern of a capillary leak, pulmonary edema, again with a high CRP induced superinfection. Patient was again put prone and on broad spectrum antibiotics, stating that COVID is a very wicked disease. So the patient is now still in the ICU after 3 months, doing fine on oxygen via TPs over the tracheostomy, and she is conscious and alert. But it's a very, very wicked disease. When you think patient is cured, things may dramatically deteriorate. But it seems that fluid management plays a crucial role, and we have to ask the 4 questions and the 4 phases. After the resuscitation comes the organ support, stabilization phase, and the evacuation phase. And this brings the acronym of the ROSE, where fluid balance should be positive initially, neutral afterwards, and then negative. So after the first hit, which is the COVID pneumonia and the cytokine storm, fluid resuscitation saves the patient and fluid balance should be positive. Then comes the second hit, which is the capillary leak and the ischemia resuscitation. And then the organ function should be optimized and stabilized. The third hit is this global increased permeability syndrome, where fluids should be removed, of course, avoiding hypoperfusion whilst removing the excess of fluids, and hence the acronym ROSE. The blossoming of the rose when you give the water, and of course the rose at the end is a dry rose, not a dead one. So the initial phase of shock is referred to as the ebb phase, and then when the patient turns well after fluid resuscitation is referred as the flow phase. But the problem is going from one phase to the other after rescuing the patient with goal-directed treatment, optimizing organ function, late conservative fluid management, stabilizing the organs, then maybe late goal-directed fluid removal, evacuate the excess fluids, and then we try to save the patient. In the early stages, we may guide our treatment based on macro hemodynamics, passive lag raise, volumetric preload, and then we stop fluids when there is the absence of fluid responsiveness, and we may guide fluid removal based on the impact of fluid overload on end organ function with a low PF ratio, an increased lung water, and maybe an increased intra-abdominal pressure. So it's important to use the right targets in order to reach the right goals, which definitely is to avoid global increased permeability syndrome. So why is this so important? Because fluid overload is an independent predictor of poor outcome and increased mortality. Fluid overload has a dramatic impact on end organ function, not only at the outside, but also at the inside. Therefore, anasarca is not just cosmetic. I believe it is bad medicine. So when should we think about starting to de-resuscitate? When the patient is not transgressing spontaneously from the ebb to the flow phase. When the patient remains in a global increased permeability syndrome and fluid overload. And GIPS is defined as a persistent positive cumulative fluid balance with end organ failure, like pulmonary edema, ileus, and increased abdominal pressure. So the big question is, how can we guide de-resuscitation? So for that, we need to know how to assess fluid overload. So there may be some clinical signs of fluid overload, which are rather aspecific, like fluid balance. You can also look at some biochemical markers, like if there is a lot of inflammation. Personally, one that is interesting is the capillary leak index. So you just divide the CRP by the albumin. Colloidal oncotic pressure could be interesting. Dilutional anemia or low proteins, also because of dilution. In burns, we used to look at the urine albumin creatinine ratio as an indicator of capillary leak. You could use a radiological assessment, either with ultrasound, chest X-ray, or CT scan, and look at some fusions or third spacing. Ultrasound may be interesting too, but the problem is, if you would ask on Twitter, what do you think the volemia status of this patient with this inferior vena cava is, you see there is a lot of dispersed results, and we really cannot assess based on a simple image. This was the image. You see a dilated vena cava, but the problem in this patient, of course, is a pericardial effusion and a tamponade effect increasing the inferior vena cava. Because there are a lot of pitfalls and conditions that have an impact on assessing inferior vena cava collapsibility index. Amongst them also the presence or not of abdominal hypertension. So just looking at inferior vena cava collapsibility index is probably not a good way to guide the resuscitation, but there may be other reasons like the presence of B lines, for instance. So to sum up, guidance for the resuscitation could be the clinical, biochemically, imaging, hemodynamic, looking at the impact of fluid overload on organ function, and maybe some future tests. So we're not going into detail about the clinical, biochemical, or imaging aspects because they're probably not very reliable to guide the resuscitation. After all, we need to individualize our treatment and pick the best treatment for the best patient at that given time. So I think there are some interesting hemodynamic assessments indicative of fluid overload. And these can be related to volumetric preload, like the presence of an increased extravascular lung water or an increased global endostolic volume, in combination with high barometric pressures, but I told you that these are not reliable. So volumetric preload and the absence of fluid responsiveness may be better indicators. In our hospital, we use a nomogram where we look at ejection fraction and volumes in relation to that. So if you would have a very low ejection fraction, the optimal global endostolic volume may be higher than compared to a patient with a normal ejection fraction. We can also look at the impact of fluid overload on end organ function, and it has a dramatic impact, as I told you, on every and single organ function. Basically, we're interested in the lungs with an increase in extravascular lung water, the PVPI, and a drop in PF ratio, and also an increase in intra-abdominal pressure. And removing fluids, in fact, with a net fluid loss of about 2 liters, you see a drop in intra-abdominal pressure and a drop in volumetric preload and lung water. I believe in the future we will have many bright ideas on how to assess fluid overload, and this could come via electrical impedance tomography, looking at lung ventilation and perfusion, match and mismatch. We could look at bioelectrical impedance analysis. I told you about total body water, the extracellular water, intracellular water, the volume excess per se, and I think isotope dilution techniques with technetium labeled albumin has been commercially made available by the Daxter device, and this can calculate true circulating blood volume. So ladies and gentlemen, to wrap things up, I believe that intra-abdominal pressure is a very important parameter to be used in clinical practice at the bedside, because it has an impact how we look at the patient in a holistic way. So if the intra-abdominal pressure is increased, this may also result in a decrease in cerebral perfusion pressure. Looking at the heart, I explained to you that abdominal hypertension has a dramatic impact on barometric preload, and we should correct them. And volumetric preload parameters are better, because it also increases PPV values. By the increase in intrathoracic pressure, we need to adjust our targets, and fluid responsiveness comes with a cutoff probably rather 20% than the usual 12%. We use abdominal pressure when we are feeding the patient in relation to gastroparesis. It is the canary in the coal mine for acute kidney injury, and maybe the missing link in cardiac-abdominal renal syndrome. We need abdominal pressure in order to understand oliguria and the global increased permeability syndrome. It has an impact on gut motility, so we may use it if the patient is not producing stool. It has an impact on hepatosplanchnic perfusion and a dramatic impact on respiratory mechanics. And I explained to you that in order to recruit the lungs, we need higher opening pressure, we need a higher PEEP, and we must think of the abdominal pressure when proning the patient. So take-home messages when it comes to fluid overload. It's defined as a 10% increase of fluid accumulation from baseline body weight. And it is associated with increased mortality, length of stay, and ventilator days. It affects all organ functions, and it's associated with this global increased permeability syndrome, which is the absence from ebb to flow phase. Sodium overload is probably equally important than fluid overload. And we can guide fluid removal by clinical and lab science. Static imaging is probably not so good. We could use point of care ultrasound, need to know the limits of inferior vena cava collapsibility index. Volumetric preload by far is much better than barometric. When fluid responsiveness is absent, so the passive leg raising is negative, this may be indicative of fluid overload. We need to look at the impact on organ function by lung water, abdominal pressure, always avoiding hypoperfusion. And I think in the future, there are some promising techniques in the pipeline. By this, I would like to thank you for your attention, and I'm open to take any question.
Yes, thank you very much, Manu. Very interesting talk, a lot of slides, and a lot of learning. We have, let me mention again, we have the attendee chat and the question and answer section in the chat. Please send your questions in. Meanwhile, a few are already there, so I'll start with asking you, if you prone the patient, can you then still measure intra-abdominal pressure reliably?
Yeah, it's a very good question. Of course, via the bladder and by using the correct zero reference point, it's perfectly feasible to measure abdominal pressure supine and prone. And this is actually what you need to do. If you turn the patient prone without suspension, you see the pressure increases from, for instance, 10 to 16. You must try by all means to put a suspension so that the abdomen can hang freely.
We had some questions in the
okay, I can maybe continue with another question. Sorry, can you hear me now?
Yes, we can hear you.
Okay, I have a question. How many patients in your ICU during this COVID-19 crisis needed lung recruitment maneuvers, and how was the response to recruitability?
Well, that depends on the phase of the COVID disease. So initially, most of the patients have a low elastance, a low lung weight, and a low lung water. So in the early stages, they're usually easily recruitable, but with a dramatic effect on hemodynamics. And there comes the point that maybe initially we recruited this patient too much with too high driving pressures and too high pressure swings that may have eventually led to ventilator-induced lung injury, or even also spontaneous breathing induced lung injury. Over the course, when the patients get fluid overloaded, they usually develop a high elastance, so a low compliance, with a high lung weight and a high lung water. And this has been referred to by Luciano Gattinoni as the L and the H phenotypes. I think it's probably more complicated than that, where you could add on top of that a low and a high intra-abdominal pressure, which then would reflect the impact on chest wall elastance. So I would see 4 phenotypes. So you would have the LL, the LH, the HL, and the HH phenotype, and the first L being the elastance, and the second L being the intra-abdominal pressure and the impact on the chest wall. So is a bit of a long explanation to the question. So the recruitability depends on the stage of the COVID disease, in addition to other factors which may be related to ventilator-induced lung injury and too high driving pressures and too high pressure swings. So that's why these patients, we needed to sedate them very heavily, because they were fighting. They were having P01s of 10, 11 with very high swings, and they needed a lot of sedation. So usually we started with remifentanil propofol whenever this was still available. We also used midazolam, ketamine. Some had additionally dexmedetomidine, and then finally some were not sedatable. We used sevoflurane via the Anaconda device.
Let me continue with a question regarding what you just explained, the high and low compliance state of the COVID ARDS. There was actually two questions. One about the use of ultrasound to differentiate the H and the L, and the other one was the use of lung water, extravascular lung water, to differentiate between the high and the low compliance. Can you spend a few words on that, please?
So we mainly used the ultrasound for the assessment of pleural effusions and maybe B-lines, but we didn't sequentially look it up during the course of the disease with daily ultrasound. I know other centers did, and depending on the experience, because it still is a user observer subjective interpretation, but we don't have this experience when it comes to lung water. This reflects to the second L or H. So the high lung water, the high PVPI, the high intra-abdominal pressure, the high volume excess, the high extracellular water, intracellular water ratio, and the fluid overload usually come together in the same phenotype. And these patients usually are recruitable with the higher peak pressures and then setting the peak to the level of the intra-abdominal pressure.